I'm the Vice President and Executive Director of Dacia's Consortium, which is the 501c6 nonprofit side of Dacia. We've been on an odyssey together, and we would like to share that with you today.
So, New York City Department of Health is a large organization. We do a lot of different things. I work for a part of the health department that predominantly attempts to improve population health through health information technology. I work for the Primary Care Information Project. The main thing that we've done is, starting in 2005 with as a mayoral initiative, we enacted a large master contract with a major electronic health record, eClinicalWorks, and worked with physicians across the city who had a high percentage of their patients enrolled in Medicaid to adopt an electronic health record that was customized for quality improvement, focused on what we call our Take Care New York agenda, which essentially is quit smoking and control hypertension and diabetes. In a nutshell, that's the piece of it that we focused on in terms of customizing this clinical decision support system. So that's where I'm coming from. You see in front of you the map of New York City with the practices that are part of the Primary Care Information Project's network, and our relationship with these providers is that when they adopt the electronic health record, they agree to give us automated transmissions of aggregate quality data. So we see, not the line level data, but we see of all, for a given practice, actually at a provider level, of all of their patients with a hypertension diagnosis, what percentage of them, over the last month, over the last year, had their blood pressure under control. So what we're doing here as a health department is trying to make population health tangible. And we've used this data source to learn a lot about health in New York City, but also to enable large pay-for-performance programs with foundations in the city and with public health funding, and to launch advanced primary care initiatives where we support providers to reach out to patients, to run registries and reach out to patients who are at risk for adverse events. So that's the background of the Primary Care Information Project. And this project that I'm going to talk about today comes out of that because it comes from a point where we were administering this large pay-for-performance program we were paying doctors, up to $80 for every patient who with hypertension whose blood pressure was under control, as an example of a payment. And in our discussions with the doctors, they said, what you'd imagine, they said, I'm doing everything I can, but some of the determinants of whether or not this patient's blood pressure comes under control is not under my control. It's, of course, no surprise to the health department because that's most of what the health department's focus is, not on physicians, but on the physical environment, environmental health, and on health promotion. But having gone down this path with electronic health records caused us to think about this framework in a slightly different way. It asks us to say, okay, so we've done this work to make population health tangible for physicians. Now we're thinking about community health, and we're thinking about the determinants of health that are not in the clinical environment predominantly. And what can we do? Is it possible to quantify population health at that level? So I have a background in religious studies and theology, so I had an interest in the work of faith-based organizations to promote health. And this is one of the advantages of working for a very large organization. Lo and behold, there was an existing program within the health department where the health department is supporting community-based organizations and predominantly faith-based organizations to run blood pressure monitoring sessions regularly after services. So over the years, the participation has fluctuated, but it's been, a couple hundred community organizations have been trained in New York City to get free monitors, and we give them paper cards, and they, I discovered, we're keeping track of blood pressure. The volunteers in these predominantly faith-based organizations and predominantly churches, we're keeping track of blood pressure readings all over the city with these paper cards, sometimes in notebooks, different methods, but mostly with these paper cards. So we were interested in this program, and all of a sudden you were sort of having worked on EHR's adoption for that amount of time. We had all these paper cards, and you get this itch, like, can't we capture this data, and can't we say something about what's going on in these church-based programs? As you'll see, there had been an evaluation that showed some impact, but that was, it was important to do, but it was difficult to do, and it was very, and so from our perspective, it became enormously attractive to see if we could find a way to in the same way we've done with physicians, to help these church health ministries capture these blood pressure readings. So, but that was, from our perspective, what mattered was whether there was a problem to be solved from the perspective of the volunteers in the churches. So we, they have a standing meeting where they come together. The ones in the churches in Brooklyn come together regularly in a meeting convened by our Office of Minority Health. And we went and we presented to them. This was interesting. I went to talk about the primary care information project, and this young guy, and I'm thinking, well, I'm gonna have to find a way to talk about health IT in a way that these church-based volunteers can understand. And I start talking about it, and I pretty quickly realize that they are all nurses. They've all adopted electronic health records in their work settings, and they know much, much more about health IT than I do. So they quickly got it, and they essentially said, okay, so you're saying that you could maybe build us an EHR for our church. And so we had a discussion to identify if that would be a good thing, and if so, why. And these were the three things that came out of that discussion. They said, number one, the main message we heard from that discussion, this was a year and a half ago, a little more, almost 2 years ago. They said, we take all these blood pressure readings. Some people have really high blood pressure. Uncontrolled blood pressure in the African American community in Brooklyn and in the Bronx is, around 40%. It's very common. People have very high blood pressure, and they take the reading. They counsel people to see their doctor. If they have very, very high blood pressure, they try to get them to go that day. But typically it's a matter of counseling, referring them to the physician, trying to get them to join the walking club. That's the interaction. Then the binder closes, the file box goes shut, and next week it's a new session, and it's just this is reminiscent of what we hear from physicians. It's just a matter of who shows up. And they said, I know that in this file box there are dozens of people over the years who've come in, have had very high blood pressure, and I don't have time, I don't have the wherewithal to sort through this file box and find those people, and if I did, then I'd have to do it again. So based on their experience of EHRs, in registries, they said it would be great if we could essentially, just sort by blood pressure as well as by, last name. And they talked about, started to talk about what they would do if they could do that. The second thing was that they, wanted to get a general sense of what was going on with the health of their community. They're interested in contests. They're interested in, in talking to the pastor about how many blood pressure readings they had taken, and they didn't have any way to do that with the paper cards. So that was number 2. And then number 3 was less defined, but they had a idea that they felt frustrated with their complete disconnection from healthcare, except in those moments they were trying to get someone in to see the doctor that day. So that was number 3. 3 was less sort of a problem and more kind of an expression of frustration. So, this is what we heard from these 11 church leaders in Brooklyn, 2 years ago, and I thought this conversation was very exciting. I felt like it was really important that we find a way to work with them to try to solve their problems. What I heard, I had this quote on here. What I heard from them was not only were they interested in learning more about their communities, but that having better access to information potentially they felt could allow them to create a context of social accountability, of where people in their congregation felt, there was an expectation that they would be checking in with the health ministry, and they would feel, the sort of social effects of, essentially being watched and observed, but in a context that's grounded in trust. So we was excited about that, and we found grant funding from New York State, issued an RFP. This was in April of 2011, and essentially defined, these problems that were expressed in a 20-page document. Issued the RFP. It was an RFP that Jim's company eventually won. So Jim's going to talk a little bit about how they, responded to it.
The RFP was, it's out on their site, and it's a very good example of having a very crisp vision of what you need to happen, getting the requirements from the people who are actually going to be doing the work. But this is microwaves before microwaves. I mean, this is stuff that people have not done before. There's no model for this. So they laid out a vision. Us and 32 other organizations clawed and fought for that. And Dacia's interest. Dacia is, if you don't know who Dacia is, besides the non-for-profit component of the consortium, it also has a personal health management application and system. And our interest is to transform healthcare. It was started 6 years ago by employers who really wanted to transform healthcare, and we wanted to facilitate these types of things. For all we know, none of these participants are members of any of the employers who funded Dacia. What we wanted to do is take IT to the next step, and we had a solution, but we didn't have a complete solution. You were able to manage your longitudinal health record in a Dacia application with plug-in apps. You were able to see your data. We have gamification, but we didn't have a community dashboard that you could use for these lay health workers to do it. So we did a partner search, and we ended up partnering with a company called NextJ out of Canada, where they do good team-based clinical care and approach, and they had a tool that was very sophisticated for care coordinators, health coaches, those types of individuals, and we basically shelled out as much capabilities as we could to simplify it, and then we used that as the dashboard side of the solution, and we've got a picture up here of one screenshot of that, that's then tied to the Dacia health system on the back end side. And what's interesting and new about this, we'll talk this a little bit later, is that these are not clinical folks, and so the lay health worker, each one of these programs, they're consented specifically, and that's different. So the consumer or the congregant has a full PHR. They can track. We have people tracking problems, medications. They're using pedometers, other types of stuff. But the lay health worker is only consented to see some demographic information, systolic, diastolic, and pulse, so it's program specific. And if there were other programs, they could see those. So they opt into that. And then we're able to pull from those records and create a dashboard. So that's the front end side of it. And then the next, the other piece of it is on the back end, and I alluded to this too, on the personal health record side, where they're able, we have a plug-in app, and they're able to then either themselves or the lay health worker can input the data. So it was very important for us to meet people in the community wherever they are. If they're not internet active, we needed to be able to give the lay health workers a vehicle to just input the data just like they filled out the card. So we were taking what they were already doing on the card side and trying to make a transition to that. But if not, they could also do it themselves. They could do it off of devices. They could do it off of their smartphone. We support all those things, and so it's wherever they're at is where we wanted to meet them. And so there's a plug-in app inside Dacia that, among other things you can see on there, measures and tracks blood pressure. That's the solution, and Tom's going to go and talk about how this rolled out and where we went from there.
Sure. So, that took a while, all the, issuing the RFP and setting the contract and so forth. And so there we are. We show up back to the church health ministers and we say, remember us, we talked about this tool that you might want to use. Well, we have one now, so what do you think? Of the churches that we spoke with originally, we ended up, when we added a few more, we ended up with 5 churches, which was our goal. I think actually it was originally 4, and we ended up with 5 church health ministries that would join the pilot, and we, put together actually put together a new sort of part of the primary care information project to work on this. Very small. We put together a training protocol, and we, went out to these churches and did the training in March, and the result is that of the 5 churches, they had, as of the end of August, the numbers are a little higher now, they had enrolled 133 congregants and captured 166 blood pressure readings. And we can talk a little more about, in a little bit, about how good that is and what we should make of that. But that's really what we wanted to know from this pilot is this tool usable in this context? Is the tool usable, and how interested are the lay health workers in these churches in capturing blood pressure readings and signing people up for personal health records? So, we have a grant from ARC, and we'll be doing with the NYU School of Medicine, we're doing an outcome evaluation next year. But I just wanted to talk you through this sort of usability pilot this year from the perspective of one church, which is called Mamre Seventh-day Adventist. Mamre is, thank you, Jim.
You're welcome.
Mamre is one of 5 churches, just mentioned them all. It's Mamre Seventh-day Adventist, Christian Fellowship Seventh-day Adventist, Berean Baptist, House of the Lord Pentecostal Church, and God's Battalion of Prayer. They're all in Brooklyn. Mamre, as you'll see, is in a neighborhood called Flatlands, which probably not a neighborhood that most people who come to New York visit. It's an Adventist church. Public health people know about the Adventists, well, for a lot of reasons, but from the Adventist health study back in the day, which took advantage of the fact that Adventists eat a lot of vegetables and nuts and fibrous food. They don't eat a lot of meat. They have a very strong health message, sort of really ingrained in the teachings of the church. This church, Mamre, is I think predominantly or entirely people from the Caribbean, and has a particularly sort of strong and active and health ministry that actually Cecily Baker from Mamre served on the selection committee selected Dacia, and is a telehealth professional who is supposedly retired, and has been, this project wouldn't exist without her. So that's Mamre. Mamre, as do many Adventist churches and many churches throughout New York City, they offer a battery of programs for their congregation. Some of them are sort of one-offs, and some of them are once a year, every year, and the blood pressure monitoring tends to be once a month. But there's a lot of different things going on offered at the church, sometimes to the congregants, and sometimes to the community at large. So I don't want anyone here to think that we went in and made this stuff happen. This stuff was already happening. So actually I'm going to jump around here a little bit. So that was where Mamre started. They have, I'm talking about Mamre, they've embraced using the dashboard more than any other church. I'll actually jump forward. Here is just this last couple months, we get utilization data from Dacia, and we've been using that to create, a pastor's report, the report that the health ministry can take to their pastor to show him or her what is going on with the health ministry, and we also use it to create, a little healthy competition between the churches that are involved, which we found to be, kind of electric. Mamre's graphs are very, very small, but you'll see Mamre is the red graph over on the left. There are 40 members of Mamre, so it's about 10% of the church, and they've really focused on their older population, what they call the adult ministry. Pretty much everyone in the adult ministry is signed up. That's what they said they wanted to start, and they do blood pressure readings with the adult ministry every week. They've taken at this point about 100 blood pressure readings, and the next stage with them is that we have given them, the health department has kind of a stockpile of blood pressure monitors, and we've given them some blood pressure monitors that belong to the health ministry, and they're going to start sort of rotating them through people with high blood pressure in the church so they can take them home. And then, so the next thing we're going to learn, we just did this, so we don't know now, is whether those people, older people, will take their blood pressure at home and, perhaps with the assistance of their family, enter the readings into their personal health record at home. So we don't know whether they'll do that, but we're going to find out. The main thing that we hear from lay health workers across the 5 churches, but from Mamre in particular, mostly at Mamre, is that they do feel that when they have this dashboard, this is what the dashboard looks like. When they have a list of people that they can sort by high blood pressure, they're just more likely to do follow-up. They just said they're just doing more follow-up, more outreach to people who otherwise, might not be coming back to have their blood pressure taken. And I hear them. I try not to. They sort of talk about the individual people and what their particular barriers are to lowering their blood pressure, and and that's so that kind of increased outreach, reported by them in these qualitative interviews we've done, is the main effect that we have heard described from this pilot at this point. So what you see here, right? So this is the kind of participant list view, and this feels, I think, to the lay health workers at Mamre and other churches like a better version of something they were already doing. They were already doing some outreach. It wasn't unheard of for them to follow up with someone who had high blood pressure a week later, a couple weeks later, and this is just better than that. Then the blood pressure entry function, which you don't see here, but it's about what you'd expect. You pick on it, you click new entry, screen pops up, you enter a blood pressure reading. That feels to them like a slightly better version than what they were doing before. The registration is a pain. They weren't having to do that before, but now once you get on the web, you have this whole consent process. But this feels, they were already doing it, now it's a little better. This is the other piece. This is the kind of let's see how we're doing in aggregate view. This is not a better version of something they were doing before. This is something they weren't doing at all before. This asking this question, sort of how, we launched a new program, we launched a walking club. Is it having any kind of longitudinal impact on the health of people that we're serving is not a question that really came up in any kind of in such a stark way before. And so, I think this piece this piece of the software, their response to it is it's just a new way of thinking, and we'll sort of see where it goes. I also think the visualization here is not as good as it needs to be, and will evolve with feedback from the users. And then the third piece is this is a printout. You can print out an individual's blood pressure readings. And by the way, it is a picture of a real person, but his name is probably not Joseph Alvarez.
It's all dummy data.
Right. But you can print out a chart of the blood pressure readings with the hope that the person takes this into a doctor. That's the extent of sort of physician integration. At this point, we have conversations with the public hospital system in New York City, because it happens to be the case that both God's Battalion and Christian Fellowship are 2 blocks from Kings County Hospital, and they're sort of interested in what kind of a partnership could emerge. But we, at this point, had a lot of conversations. We really don't know. But the fact that, they're creating these charts and capturing data seems to have sparked that discussion, which it's not like the churches are new. They've been there, they've been 2 blocks away for years. So that's the state of, these are sort of the state of where we are in terms of solving those 3 problems that we talked about in the beginning. And then the pastor's report, gets at another problem. They didn't express so much sort of engaging the leadership of the church, building the institutional capacity for running programs and getting that buy-in, which is very important for the sustainability of the programs.
I'd
Would the individual get that report from the church then if they wanted to get the historical data and take it to their PCP?
Yeah.
Or they can log on and do it at home too, if they're if they're internet savvy. Yeah, right. So again, meeting them where they're at. The other component of that dashboard care front end from in our NextJ partnership has a campaign management component. So again, you can see we took some very small steps because we didn't want to throw everything at them at one time. I think a lot of us will sit and we immediately think there's clinicians using this, and you'll immediately go to a nurse court. These, even though many are retired nurses, the concept has to be driven to someone who could be the pastor's husband or wife and has no clinical background. And so that whole campaign management is another piece we can put in where we can run, again, by health status and other elements, and do it in the ways they want. So if we can send them text messages, we can send them emails. We can also print out contextual, hypertension for African American population right there at the moment of interaction. Can't call it care, right? Interaction, to be able to do that. And so there's lots that we could do, but we just are taking baby steps because this is all brand new in terms of understanding. Some of the other couple things that we have on here is that we do have people who are using other parts of the PHR to, as I said earlier, to track other things. So they've started to explore. They started to look at the applications we have. They're tracking other kinds of data, and I think that's helpful as well. And then, and again, I mentioned it earlier, the consent-based, program-based consent model. There's going to be a lot of applications for that type of a process. We really wanted to understand what we needed to do there as we get into more extended medical homes and ACOs, and we really get to integrate the community. We've got to figure that out from a privacy and a process and a usage standpoint. And then, it was, I'll tell you, it frankly was very easy for us to look at what we could do and look for a partner because they did such a great job on the requirements. And I can't overstress that because, again, there was a vision there of something that didn't exist. The solution didn't exist. And also, as you go through downstairs at the, through the solution stuff, this last piece about loosely coupled components, that's the future. It's not going to be one monolithic stack. You're going to have to be able to have these different programs and capabilities work together. So through our application programming interface, we were able to easily tie the next gen dashboard to the Dacia system. And so, these are early. This whole process is early, but we're very encouraged by where we're at this point. Some of our challenges, Tom alluded to it, for onboarding, these congregation members and these church people, many of them have known each other for a long time. They don't need to be authenticated. But in our system, you do. We need to know who you're at because our system has the capability of being able to take that data and send it through an HIE to a physician and be used that way. So we want to make sure you are Jim Hansen. And so that seems like a big barrier for those folks. So we're working through trying to figure out how to find that happy place there. Usability. That's a tough one. How do you take a very complex health coaching and population management tool and take out things and put capabilities there that's not too much or too little to help them manage their populations? That's a challenge. And how do you do that so you're not creating something completely different? So that's been a little bit of a deal. The point on the cell phone is really interesting because of the way Dacia worked. We were using email, but what we're also getting from the bipartisan policy work that we're involved in, as well as some of the IOM consumer engagement stuff, now the whole unique identifier issue is starting to come up again. And what are we going to do? And for most people, the thing that they now stays the same in their life is their cell phone number, and so so we're going to look to that as an identifier. A couple of other sort of process related things, but being able to the program intervention tracking, you can assign people to campaigns and be able to do this, but it's not an easy way to do it because it really was set up for nurses, and so that is a challenge. That is an enhancement we're going to have to make.
Yeah, I'll just pick that up because I think this is pretty interesting. So let's go back to, let's look at this graph here. When they showed us this graph, and I don't mean to pick on NextJ, they I think they built what we asked them to. But look at this graph and you say, if what you want is you're the health department and you're launching a program with a given faith-based organization where you're supporting something, or say you're just a faith-based organization, you're launching a program and you want to, you want to know what the impact is. Not in a, you're not doing a controlled study, but you're doing a little observational study and you want to generate an insight. So what's wrong with this chart? If this chart shows you, these three modalities of control of, blood pressure outcomes across the population of the church. Well, one problem is that for someone whose blood pressure is very high, they can reduce their risk significantly without, without becoming yellow here or green. So you can do a lot of good work and you don't see it here. That's a kind of visualization issue. But the issue that Jim just alluded to is that most of the change you're going to see in something like this is new people, coming into the program. This isn't all. Anyone who does evaluation would think about this. So, it's interesting. This is actually not something that gets dealt with in EMRs very well either. But what they really need in the kind of next build of the software is to say, okay, walking club, we're assigning a tag to these people in the walking club. We're setting a baseline. These are the people in the walking club. It's not going to change, and and we're going to track that over time. So it's fairly sophisticated, but relatively speaking. But that's really what they'll need to get to that second point about answering the question, how are we doing?
You're saying the exact same domain, consumers, people, like, without changing, like, you're gonna take 10 people at the beginning, and you're gonna track those 10 people throughout without introducing other participants?
Yeah, I think that would be the idea. Otherwise, a chart like this gets very confusing, you know. And I think that is how programs work in faith-based organizations. They tend to have these cycles, but you need to be flexible. You need to be able to kind of respond when the tool needs to be able to respond when the next cycle comes around. You're assigning a new group of people to a program. So that's all. And that's not a problem particular to faith-based organizations, but it is one that's come up here. So just to there we go. Sorry.
And just to, I think we'll just move on to the next slide here. To wrap up, it was very interesting to when the latest IOM, major IOM report came out that focused on what do we need to do to go forward. Its title was a little bit misleading, Best Care at Lower Cost, the Path to Continuous Learning Healthcare in America. I've been involved for the last couple of years in the learning healthcare system work groups in IOM, and it's, it's one of the major components is to be able to reach out. In this country, we need to utilize non-cost-based resources to help solve our healthcare problem. It's that simple. And so we need the consumer patients to be engaged, but we need to activate their networks. And their networks could be online social networks, or their networks can be family, or they can be faith-based groups. And so, so this again is one of the major tenets of moving forward under that program. And that sort of ties it back together as New York City Public Health had the vision, and then this is the journey we're on, and it'll change. Like we said, we're going to adjust some of the variables, roll it out to more folks, potentially connect it to the HIEs. There's a strong set of health information exchanges in New York City, and also to go out to other types of groups, community centers, other folks. But we wanted to keep it pretty limited now to make sure that we weren't going to go and do something, stub our toe, try to get it right, then do that.
So I'd say, just in summation, to this, for those of you who are working in, disease management, care management, I want to finish with an anecdote, which is, when I started talking to the volunteers in these churches about the Primary Care Information Project and what we were doing, I described the pay-for-performance program that we were running at that time. It was focused on blood pressure control, and I was saying, the physicians get, $80 for every person who gets their blood pressure under control. And I remember one woman said to me, let me get this straight. We're taking these blood pressure readings every week. We're running walking clubs. We're having free cooking classes. And the doctor gets paid $80? This patient hasn't been to the doctor in 9 months. So the point is, when you consider whatever your work is, when you consider the population that you're seeking to, health you're seeking to improve, think about all of these kind of circles of care that are going on, and think about ways to make, these community organizations, not to make them count, but to give them credit for the work that they're doing, and to build them into your strategies. That's what we're trying to do, and we'd love to work with anybody who's interested in that. So thank you for coming today.
Thank you. Any more questions? Yes, sir.
How many thoughts around how does EHR integrate into the larger EHR coordinating with physicians and what they're doing with the patient?
Well,
Plans going forward to coordinate this, but anything that they're doing with their normal doxing?
So at this point, I'm having this conversation. At this point, so what's the value? Does the doctor want all of the blood pressure readings that are being taken in a community setting? Maybe some doctors, not too many that I've met. I think the first step well, I'd say two things. The first step is, to figure out, you want to have some kind of message. You want to have some kind of secure, reliable way to, get the message from the community organization to the physician that this patient is high blood pressure and is sort of participating in some kind of programs, and then, potentially depending on what sort of differences between these different health ministries, I think there's potentially an opportunity for the doctor to send back, kind of a basic, here's what I'd like this patient to be doing. That would be, I think those messages it's not data, not the first thing that comes to mind. So I think that's how I would imagine it based on conversations we're having with health systems. That's the kind of the first kind of communication that goes on. Jim, I'm sure, has other.
Well, yeah, more active for different programs. Obviously,
Right.
for diabetes, yes, they would like to see it, but it's to create an interaction between the three parties in between the 6-month visit, and that's really what it is how can you smartly move information and education back and forth to support, to support the ongoing congregants, activity, and not, gee, I better get this down, 3 weeks before I have my 6-month appointment. I mean, that's what we all know in engagement. It's got to be continuous. It's got to be smart, and it needs to be active. It cannot be that passive. So technology-wise, we can do what Tom's talking about. But this is more of exploring the culture and the needs side of it. It's not a technology. We're doing that work in the state of Montana in their HIE, moving our PHR stuff back and forth with the clinical systems up there. So it's not a technology problem.
If you had physicians who were interested in, team-based care and, didn't necessarily want patients coming in a lot, then you could imagine a relationship where the information that this patient's blood pressure was under control would be very valuable. That's not, the context of care most of the time. Yes, sir.
Does it have to be faith-based? I mean, I get it, and I understand that there are many churches that provide this service for their congregants. There are also many churches that don't. And I suspect that as a result of this, you may not just do it. But there are other community-based organizations that might want to take advantage of this. We've gotten any noise about that segment of the community. The second thing is, I wonder, I've been seeing Mayor Bloomberg on TV a lot. Have you gotten any positive vibes from the mayor's office that this is a really good thing? You'd like to see this continue, or is he still all about sugary drinks?
Let's see. So the first one, absolutely. There's nothing. Certainly not just churches. To be clear.
But it said pastor's report.
Right. Well, that's tailored to this pilot group. But it's any place. You have to ask yourself. It has to be some place where people know your name, and you go regularly. So senior centers also run programs in New York City that are actually built on the exact same protocol that the Keep on Track. We've started talking to a fraternity. I didn't know these fraternities meet like constantly. Turns out so anywhere, I've belonged to a cooperative grocery store. I've started to think about whether I could start something there. So yeah, absolutely. I think about 60% of people attend a religious service once a month. So a lot of people attend churches, but a lot of people don't. So that's an important question. In terms of Bloomberg, haven't spoken to Mayor Bloomberg about this this initiative right now. We have presented it to the commissioner, and I think Mayor Bloomberg is someone who is just interested in results and success, and so if we can show that this is an asset and he's obsessed with health, so show that this is an asset for the health of New Yorkers, then I'm sure he'll be all for it, although his term is up in a year.
And one last question. This was started out with a grant, and there's money out there to support all this. What happens when the grant money runs out? Is this self-sustaining?
No, I mean, nothing's, well, so, right, so it could be self-sustaining if the churches would pay for the software. Yeah, we haven't run that experiment yet, you know, you know, the costs, there's a lot of things, there are a lot of upfront costs around the development. Yeah, so we shall see.
But I guess I want to hear from Nasi on this. I mean, once the infrastructure's up and you've got, I guess, the server space assigned, it's not that much additional incremental cost, right? I mean, it's all.
Right, and most of what we had was our core product. I mean, the idea was to leverage that, but even a very small amount of money is a lot to a church. And we had lots of discussions about sustainability way up front, even during our sort of negotiations and stuff. And because this is so new, we needed to know what the value is, and I think that's going to determine it. You know, whether that's something that either that they will subsidize, and you're right, it's not going to be a significant amount of money, or whether it's something people will do themselves, just as they do many things themselves for church-type programs. Would they do? We don't know yet. We first want to just see, is this useful, helpful? How does it work? Because we're really testing this new approach, right, of lay health workers being very active and interactive with the folks. Great question. We felt like we had to defer that. And we've
Yeah.
got to produce more value. I mean, we've got to make the next set of reports, I think. That'll happen.
Yeah, the way I think about it is, you know, if there's a market in, you know, when Tom Frieden, well, always at the health department, if you can show that you're lowering blood pressure readings, then you can get funding, you know. There are probably similar kinds of markets in, you know, health insurance for ACOs. I know blood pressure control is a quality measure. So now these efforts have a shot in that market. Before, they weren't even on the exchange. That's the deal, you know.
Yeah, as you get to payment reform components, if you're thinking about it, this is going to be a very minor investment for an ACO or a medical home. If I've got people out helping me, you know, get those patients and move them along, that's all to be explored. It's a great question.
Yes, ma'am.
I was just wondering if you had heard about the study that was published in 2002 by the NIH Women's Health Initiative done in Baltimore, and it was called Project Joy. It was tailoring the health interventions to the cultural aspects of the church, spiritual aspects of the church. Basically, it made a significant difference in the interventions, made a significant difference in the African American population. So they incorporated things like prayer into the health messages. The pastor incorporated health into his messages. Instead of aerobics, you had praise and worship dance. And I think that that's a critical aspect of, it made a significant difference in health outcomes during those churches in Baltimore. So I'm just offering that as another suggestion for.
Sure. You know, there's an incredibly rich literature of, you know, evaluated academic studies of faith-based health promotion, you know. And I think, as you allude to, the ones that, you know, are immersed in the message, the teaching of the church, probably are more likely to be successful. But, you know, the question we have to ask, and the problem we're trying to get at here is, so why are we continuing to do that study over and over and over again? We know that, you know, you can make people healthier by engaging them in their place of worship, you know. But I know of at least 3 studies in New York City that are studying that exact thing. It's been going on since, you know, the 90s. And so how do we move, you know, to the next stage where we're actually scaling this up, you know, to a population level. Yes, sir.
But your point about in the context of it is a very important one. So again, based on your ethnicity and stuff, we can have it print out along with their charting. We can have it print out customized materials you know, to what their situation is for whatever that program is, and you know, and do it that way. And I brought that up, and you're right about the cardiovascular health. Thank you for that.
Yeah, it'll be awesome.
Okay.
Yeah. And they had a secular arm of the intervention that said in the church, and it said the woman couldn't be alone. It did not become secular, it did not remain secular.
Mm-hmm.
And so that just shows you the power that the congregants have, making it something seen.
Yeah.
On this issue of sustainability, it strikes me that you have something here that ought to be a really focused, priority of the city. I mean, I was listening to you and I was thinking about at an admin interface, if this were a tool that was marketed to all, well, say all businesses as well, businesses and member organizations, you think of small businesses, the best hope we have to get them to do anything for their employees related health is probably to get them into community level initiatives. And so here's an opportunity to get them connected, getting very individual, very specific feedback. So I envision this sort of network of employers and churches and business organizations and any type of organization across the city using this, and then think about this, the city changes a policy, which you guys seem to do a lot, even up in Maine where I live. I read about your policy changes all the time when sodium and sugar or whatever. You change a policy, new law comes out, carrier has benefits change. Wouldn't you, through the software, have the ability to send targeted messages to the people who have said risk factor or issue that policy change or some benefit change relates to? It seems that you have something incredibly powerful here.
Thanks. Yeah, no, I mean, yeah, we would love to, that's what we're gonna do. We're gonna keep on the work and study it, make the case that the work, the work of community health workers, volunteer community health workers, is worth measuring, and is effective. That's the path we want to go on. Yes, sir.
So how much time do the community health workers spend trying to make the connection between the congregants and a stable source of physician care? I'm getting the sense that that's not necessarily all in place with some of these people.
So so your question is what proportion of that, of the sort of all the volunteer time that they're given?
I mean, sort of the teaching I've had is you don't screen unless you have a follow-up that you can be pretty confident will achieve what you need to do, that somebody's going to then get care. Well, does that happen most of the time, all the time, occasionally? To what extent is there even pressure to bring a doctor in and start treating blood pressure? I mean, does this work, I guess, as a screening mechanism to get people's blood pressure controlled?
Well, so the paper-based intervention was evaluated in senior centers, and it was evaluated on the basis of people who returned for a second reading and what was the difference over time, and there was a small impact. But I agree with the gist of your question. I think just screening, we don't think just doing screening and monitoring, which is what you see everywhere, is a particularly effective intervention. What makes that intervention effective is, if you can increase healthcare access, because healthcare has, some marginal impact, or if you have someone who's effective at counseling and, doing motivational interviewing. So, it's very hard to know whether those things are happening. So I guess to answer your question on the basis of my experience, just spending some time with these churches. So in our protocol, blood pressure, same as the JNC, 140/90, either one. But if anyone's blood pressure is either over 180 systolic or 110 diastolic, got that right? you know, we tell them they should get that person into care that day. You know, and New York has a public hospital system that anyone can get treated. We actually have very low levels of, very high levels of healthcare access compared to other places. And so there are barriers, but particularly when you have someone in the church who's a nurse or a physician's assistant who can get on the phone and advocate for you, you know, anecdotally, I see that as being, as being, you know, as working. You know, so I think if that's your goal, of getting people into care, then you know, I think this works okay. That's actually just one of our goals. I mean, you know, if we thought that was the solution to blood pressure control, you know, we probably wouldn't be doing this program. As I said, healthcare access in New York is pretty high. The problem is that you have a lot of people who are in care who blood pressure isn't under control. It's not that, you know, they could see their doctor regularly, it's still not under control. So, you know, what we, by trying to build an information interface that encourages, you know, a kind of stronger, longer relationship that's about, you know, walking, eating differently, and medication adherence, that's where we see this as, you know, as more, you know, as being more effective, because we think that, you know, there are important peer effects in terms of the behavior that are important for hypertension and other chronic diseases.
All right. Thank you very much for your attending our session. And if you have any questions afterwards, let us know.